This is NNI Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. We are joined by the chairs and speakers of NNI and WNSC Workshop 102 as they share practical insights on the impact of proper nutrition that contribute in the optimal growth of children.
Hello and welcome to the Nestlé Institute podcast NNI Bites Big Learnings with the series from the Nestlé Institute Workshop 102, Growing Strong, Harnessing the Power of Nutrition for Child Health. I'm your host for today. My name is Bert Koletzko. I'm a professor of pediatrics at the LMU University of Munich, and I have a great pleasure in being joined by Vincent Jaddoe. He is a professor of pediatrics with a focus of epidemiology at the Erasmus University Medical Center in Rotterdam, and he also holds a position as adjunct professor of epidemiology at the Harvard T.H. Chan School of Public Health in Boston in the United States. His research focuses on embryonic, fetal, and childhood developmental processes and its relationship to health and diseases across the life course. And he's very well known around the world for his strong involvement in the Generation R study, of which I'm sure we'll hear more in this podcast, and also for bringing investigators from cohort studies across Europe together in joint cohort study evaluation. Welcome, Vincent. Thank you for joining.
Thank you, Bert.
So in this workshop, you had a really fascinating presentation on early life growth and later cardio-metabolic health. And one of the topics you discussed is the role of maternal body weight and maternal obesity for the offspring health. Can you elaborate a little bit on what are the key findings?
Yeah, so first of all, maternal obesity is very prevalent. So women among reproductive age, the prevalence of overweight or obesity exceeds, in some European countries, 30% already. And in non-European countries, including South Asian countries, the prevalence is also increasing up to 20 to 25% already. So it is a major public health challenge to address the prevalence of maternal obesity during or before pregnancy, but also the consequences in the offspring. So what we did is to, first of all, explore what maternal obesity and gestational weight can do on the offspring. And we first of all observed that it is not maternal gestational weight gain during pregnancy which is most relevant, but especially maternal obesity before pregnancy, so when women want to become pregnant, or in a very early stage of pregnancy, which has the most important consequences for childhood outcomes. And we mostly studied childhood obesity, which I discussed this morning. But I think what is most important to recognize these days is that weight status of mothers and fathers-to-be, so actually before pregnancy, is most important for health in the offspring.
This importance, I think, cannot be stressed enough. You published a paper jointly with Dr. Foreman where you showed the relationship between maternal body mass index and the body mass index of the child. And the surprising finding was that the impact of the maternal body weight on child body weight becomes bigger with increasing age, which is almost counterintuitive. With most exposures early on, you would think they are more diluted with increasing age of the child because other factors come in. So how do you interpret this amazing finding?
Yeah, so indeed it's a paper from Alice Furman, published in PLOS Medicine a couple of years ago. And she actually used data from many European birth cohort studies coming together in the EU Child Cohort Network. And she showed actually that the association of maternal BMI with childhood BMI or childhood overweight is present across the full spectrum of maternal BMI. So it's not restricted to maternal obesity itself. And the second thing, and that's what you referred to, is that the association or the strength of the association, the effect estimate, becomes stronger when children become older. That might have several reasons, but I think what's most likely is that offspring of these mothers and also the fathers adapt nutritional factors or lifestyle habits from their parents. And that's why I think next to the programming, early developmental programming effects on maternal weight, on childhood weight, also the programming effects of their lifestyles has a role. So I think we do know that nutrition of children is strongly related to nutritional habits of the parents. So I think that's it has two steps. So the fetal programming effects and the lifestyle programming effects at later ages.
Yeah, that's amazing. You mentioned before that the effect of maternal obesity or body weight before and at the beginning of pregnancy is bigger than the effect of gestational weight gain in your data. Now, in clinical practice, I perceive that the focus of pregnancy care is very much on gestational weight gain. So that's an important message for clinical practice. Can you explain a little bit what your findings are in this regard when you compare the two factors?
Yeah, so we try to disentangle the effects of weight status before pregnancy and during pregnancy, so the different trimesters, by separating the weight status in these different trimesters. And when you look at the effects on BMI of the children at the age of 10 and also fat measured at the same age, you do see that maternal obesity before pregnancy, so when women enter their pregnancy, or actually the weight status in the only first trimester of pregnancy is most important. And we do know that gestational weight gain is very high in second and third trimester of pregnancy, but actually we do not find associations with outcomes in childhood. So that leads to our conclusion that when you want to address the effects of maternal obesity, you should start as early as possible and preferably even before pregnancy. That's difficult because in most countries, women do only enter healthcare when they are pregnant and even when they are beyond first trimester of pregnancy. So I think the findings of maternal obesity before pregnancy and first trimester effects are really supporting the importance of preconception preventive care. So when you really want to address the effects of preconception obesity on childhood outcomes, you need to see these women and also their partners already before pregnancy.
That's a really important message, and probably you have an opportunity to start even in adolescence to promote health in adolescence and healthy body weight as a preparation for parenthood. Now, in a clinical practice, many of our colleagues in obstetrics and general practice look at the guidelines of the Institute of Medicine for gestational weight gain. They advise women to strictly follow those. Is this a good idea? Is this based on good data?
That's an important question, I think. So what we did in Europe, we established a big network of European birth cohort studies, collaborating now in the EU Child Cohort Network. And we had the power to use these data of more than 200,000 mother-child pairs to address the question, what is the optimum gestational weight gain? And when you just look at the data rather than the Institute of Medicine recommendations, you can actually see when you use the outcome maternal and birth complications, so preeclampsia, gestational weight gain, low birth weight, high birth weight, preterm birth, where you can make conclusions about the optimum gestational weight gain per BMI category in these women. So when you look at underweight, normal weight, overweight, obesity grades 1 to 3, you can make conclusions about what is the optimum weight gain for these specific groups of women. And we did actually observe differences as compared to Institute of Medicine conclusions. So our recommendations, especially for the higher weight group, so the obesity grade 2 to 3, are really different as compared to the Institute of Medicine. And I think the strength of our approach that we used real data, so it was data driven, and it is based on contemporary populations actually throughout Europe. So I don't think the conclusion about gestational weight gain optimization is now finished, but at least we do know that obesity grade 3 women, for example, do actually have a maximum weight gain of only 6 kilogram weight gain during whole pregnancy, or just should lose weight, rather than what we thought they should gain some weight, even although they are really obese grade 3 already before pregnancy. So actually, when you are really heavy or obese before pregnancy, the recommendation should be to really limit the weight gain during your pregnancy.
That is truly a change of paradigm, a complete different approach. So that's really important and probably needs to be looked at further with further data and intervention studies, I guess, to substantiate that. Well, that's really great.
Yeah, and maybe important, this is only focused on birth outcomes, so pregnancy and birth outcomes. So we're trying, of course, to do a similar analysis on childhood outcomes, which is maybe more important. So that's the next step.
Yeah, we're looking forward to that. Now, in clinical practice, people look at weight and body mass index, but what are other predictors? Would it be interesting to look at body fatness of the mother? What about diabetes? What about her dietary habits and other lifestyle habits? What is important?
I think to give this simple answer, a lot of these exposures are important, but when you look at practice, so it's very difficult to already address BMI in before pregnancy. So you can indeed make it even more challenging by including micronutrients or supplementation, etc. But what we observed is a very large part of the effects of BMI explained by BMI of both parents, so mothers and fathers. So what we do in the Netherlands is actually to try to modify BMI because we think it's such a strong effect on the children. And we think if we can make that successful, you have already a strong effect. And of course, from an etiological perspective, you look into the mechanisms, the fat mass of the mothers, of indeed their nutrient status, also their micronutrient status, is important, is really important. But it's even more challenging to address these factors than only BMI.
Well, I'm delighted to hear as a male and as a father that the father has an influence as well on pregnancy and child outcomes. Why is that? Is it because of shared lifestyle with the family, or is there other biological mechanisms by which the father's health and the father's body mass affect the outcome of the child?
Yeah, I think, first of all, it's really important to shift the field of early life programming of adult diseases or non-communicable diseases from only the mothers to the mothers and fathers. And first of all, that is important because indeed the fathers do have their own effects on childhood outcomes. The mechanisms are maybe unknown, but might also include programming by sperm of semen composition. There are studies on that. You can also see in observational studies in the data that even, for example, paternal BMI has strong effects on childhood BMI independent of the mothers. But most importantly, if you want to optimize lifestyle of future mothers, so young women who want to become pregnant, you need help of their partners. It doesn't make sense to only focus on the mothers because these couples do share lifestyle habits, nutritional factors. So it does make sense, clearly, to involve the fathers also in future preventive strategies.
Absolutely. We've learned the same with breastfeeding promotion. If we don't involve the partners of the breastfeeding woman, we're not successful really in promoting breastfeeding. We have to really involve the whole family. Now, another question is the risk of child obesity being influenced by postnatal factors. And you have found that not only intrauterine factors, but also the combination of slow growth in utero and fast weight gain after birth is a real risk factor. Can you elucidate that a bit more?
Yeah, when we go now from the mothers to the fetus and infants, of course, what you do see is that there are well-known associations of having a low birth weight or high birth weight with outcomes in childhood. But when you use more dense data in early life, you can also make conclusions about specific growth patterns. And what we observed is that there are actually two groups of children prone or susceptible to develop, for example, obesity, overweight, or even liver steatosis. And these are, of course, the children with a high birth weight remaining large, so without the catch-down growth. But we also observed that children with fetal growth restriction in the third trimester of pregnancy, most frequently leading to a small size or gestational age at birth, followed by a growth acceleration, have the highest prevalence of liver steatosis and liver fat, which is really remarkable. So this really strongly supports the concept of mismatch. So if you have a fetal growth restriction or an adverse fetal environment followed by a fetal growth acceleration, you may have the most adverse profile in later childhood.
I guess that's a really important message for practice, because oftentimes we see that families who have a baby born small try their best, the mother, the grandmother try their best to stuff it so that it becomes as big as a neighbor's baby as quick as possible, and they give them extra calories and extra meals and more frequent feeding just to try to push the birth weight up. And you're saying this is really not a good idea because it could markedly increase risk if we overfeed and we make the child gain weight fast, right?
Yeah, the only thing we should not simplify it, because I was also trained, it's not only the parents but also healthcare workers.
Sure.
When you have a small child, you want to grow it as fast as possible, to come in a safer range of all kinds of things. And you need to take into account also other outcomes, so including brain development, even survival for preterm born children. They need to grow because then they are more able to keep their temperature right, or to do anything what term babies are doing normally. So it is important to balance the risks and outcomes. So it is a little bit difficult, but for cardio-metabolic profiling, it's indeed, when you look at small-sized babies born term, let's make it simpler in that way, then you keep in mind to keep the rate of infant growth not too fast. Yeah.
Sure. Well, your work is really important and gives us a lot of new insights. What are your next steps? What is your next big project?
I think it's important to keep the field of developmental origins of health relevant for public health and also for clinical practice. So what we are doing now is to combine findings from observational studies with either mechanistic studies, which are focused on metabolomics, for example, or epigenomics, but also on translational approaches, including intervention studies. So I think what's most promising from our work for clinical practice is, first of all, developing prediction models to try to identify groups at risk in a really very early stage of life, from even the preconception period, and then outcomes in the children. And on the other hand, we try to develop new intervention approaches also in the preconception period to optimize lifestyle, stress, and nutrition, so in mothers and fathers to be, in order to improve outcomes of their offspring.
Great. We will look forward to hearing more from Rotterdam and from your group. For now, thank you very much for sharing your knowledge and your insights. And this concludes today's episodes. I thank not only you, but also our listeners, and hope you enjoyed this episode. If you want to listen to more, don't forget to subscribe to the Nestlé Nutrition Institute 365 app or the NNI website. Thank you and goodbye.
And that concludes today's episode. Thank you for joining us for this special episode from NNI and WNSC Workshop 102. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.